It's an honor for me to be able to share some of our experience here at the University of Chicago, as well as some of the worldwide experience we've seen with GREAT and also insights into EVAR and use of the IVE device. As I mentioned, there's over 5,000 patients enrolled. The access method was about half percutaneous. And obviously, as time has gone on, more treating physicians have become comfortable with the percutaneous approach, even for the large bore access that's required for thoracic aortic treatment. Cutdowns were performed in 57, almost 58%, and surgical conduits were only necessary in about 2% of this population, which is excellent. Majority were femoral artery access. There are a group of physicians in the registry that use brachial access as part of their procedure, and that showed 3.2%. The hospital stay is variable depending on the part of the world you live in, but the mean hospital stay was 5.4 days. The total number of Gore devices implanted is over 12,500, and per patient is about 2.5. When you look at all of those devices and break them down into the different components, about 3,700 of the main body devices with over 5,700 contralateral legs, a small number of extension cuffs as well as iliac extenders, and iliac branch components were used as well. You can see as part of the transition that occurred with the technology during the registry data accumulation, we went from the original tag device to the now C-tag device. And in fact, now there's active control, which is not part of the registry, but the C-tag device was over almost 1,600 patients that were treated with this technology, 1,600 devices. When you look at the key outcomes, the number of patients available for AAA was 3,274, a mortality rate of 18% over 5 years, which when you compare to some of the historical data that's been collected over 5 years for EVAR, is really great mortality outcomes. And I think shows you that we're doing a better job, partially with patient selection, but just overall with our patient care with a really excellent survival rate. Stroke and TIA is very low, and you can see the other complications here also being low, with a low need for additional surgery and also a very low need for device-related interventions over a 5-year period of time. This data to me is very impressive. We want to see sacs shrink. We have a sense that patients have better survival with sac shrinkage, and clearly when we treat an aneurysm, that's our goal. When you look at the 5-year data now, over 200 patients that were available to assess, we have a sac regression rate of almost 64% and an enlargement rate of only 12%, which I think is really outstanding when you look at the complexity of aneurysm anatomy that was treated in an on-label and off-label registry. The endoleak rate is exceptionally low at a little less than 6%, and the type 1 endoleak rate, either 1A or 1B combined, is only 1.6%. The type 2 endoleaks that were collected in the registry are serious by definition, meaning they required an intervention. So this type 2 endoleak rate is fairly low. And so when you look at this, you think the data is not, potentially think the data is not believable because of that. But what is being accumulated here is when a type 2 endoleak required intervention. And you can see an exceptionally low rate of migration, compression, and an aortic rupture rate of 0.3%. The length of follow-up I already mentioned. The freedom from aneurysm-related mortality is 99%. Freedom from reintervention is 95%. Exceptionally low conversion rate to open, exceptionally low rupture rate, no migrations, and as I mentioned earlier, a low type 1 endoleak for both 1A and 1B. I'm going to discuss limb occlusions a little bit later in the paper that I present specifically to me, but the limb occlusion rate is exceptionally low with this device, and I think is really one of the major advantages of this technology is how flexible the limbs are and how well they do in complex anatomy.